Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for the MAVEN project. Thank you all for joining us today and our friends at Manic Community Health Center for hosting today's session, Cancer Screening, a Primary Care Approach with Dr. Carrie Horwitch. Dr. Horwitch is an outpatient primary care physician. She's also a certified specialist in care for patients living with HIV. She worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an associate program director and key clinical faculty. She is a clinical associate professor of medicine at the University of Washington, Seattle, and Dr. Horwitch was the governor for the Washington chapter of American College of Physicians from 2010 to 2014 and served on the American College of Physicians Board of Regents from 2014 to 2018. She is currently a member of the Board of Trustees for Washington State Medical Association, and we are just so very lucky to have her as one of our MAVEN Project volunteers. With that, I will bring up your slide deck.
Thank you so much, Kristen, and thank you to those who asked for this talk. So what I'm going to focus on is the 5 major cancer screening that we do, and I'm going to try to present this as a primary care approach. It's going to be a lot of information in this talk, and I'm not going to present absolutely all the data. And just be aware that, again, these cancer screening guidelines do change over time. So I hope I've updated it a little bit to what is new in some of the guidelines. Next slide. Just to let you know that I do not have any disclosures of any relevance, and MAVEN is the accreditor, as we've already heard from Kristen. Next slide. So I want to state that what I'm going to do is review some of the current guidelines for cancer screening, and I really want to emphasize that the cancer screening is for asymptomatic, average risk persons of what I'm talking about. If someone has symptoms, that is no longer screening, that then you move into diagnosis and diagnostic testing. So please remember, screening is for asymptomatic and average risk. There are different screening guidelines for higher risk in each of these groups, and I don't have time to go into all the high risk screening. But I hope I've given you some links in there that you can help identify some of the higher risk patients. So for this talk, we're going to cover cervical, colon, breast, lung, and prostate. I also want to discuss a little bit about what's said about when to stop screening. Really try to focus a little bit on what might be considered a higher value practice. Again, that doesn't mean that you should not screen people based only on that. And then also a little bit about what are the benefits, some of the harms, and some of the limitations for these screening. And again, just to reiterate, I'm not covering the high-risk populations. Next slide. So cancer statistics for 2023, as you can see on male side, the number of new cancers is highest for prostate, then lung or bronchus, and then colon and rectum. If we go to women, the highest incidence is breast, followed by lung, and then followed by colon. Next slide. If we look at deaths, however, lung cancer tops all of them in both men and women for deaths, and then prostate for men, breast for women, and then colorectal cancer remains number 3 for deaths in the United States. And I'm focusing on those 3 plus 2 others because that's where we actually have data for screening tests that are available. Next slide. I do just want to say also that there is differences in terms of survival rates between white and Black, and this does bring up some of the equity and disparities. Breast, colon, pretty much for all the cancers, there is a lower survival rate. That is most likely due to lack of access, due to lack of screening, and possibly due to lack of getting appropriate timely treatment for that. Next slide. So let's go over what really are the screening criteria for cancers. What we try to do with screening is detecting a cancer in a preclinical phase or a very early phase. We also want to try to focus on cancers that are destined to cause death. We could argue some of that with some of the cancers we'll talk about. But if we don't intervene, then likely those may progress, leading to a metastatic condition and therefore lower rates of survival. These also are cancers where early treatment is more beneficial than waiting until the cancer is clinically apparent. And there has to be a mortality benefit. So I say that very specifically because it does not talk about morbidity from any of these cancers or from the screening. So really, when we look at cancer screening and its benefit, we are looking at that there is a 10-year survival benefit. If we identify the cancer early, then we actually give them a longer survival time. And of course, the screening benefits should definitely outweigh the harms of screening. We try to have most of these screening tests be cost effective and cost beneficial. And again, I want to emphasize, if a patient has symptoms of any kind that is not a screening test you are doing, if a woman has a breast lump, you go to a diagnostic workup. If a man has urinary symptoms, you're going to go to a diagnostic workup for possible prostate or other issues, and so on and so on. Rectal bleeding or anything else that requires diagnostic workups, not screening. Next slide. So I'm going to go from what I think is the easiest screening to ones that are a little bit more challenging given the data. So let's start with case one, which is cervical. You have a 19-year-old who states she is having sex, coming in for her annual exam. So which of the following should be done? Should she get a PAP without the HPV, chlamydia screening, and HIV? A PAP with HPV, chlamydia screening, HIV? A PAP without the HPV and chlamydia screening, or chlamydia screening, HIV, and hepatitis B vaccine? So if you just want to put A, B, C, or D into the chat as to what you think, or into the QA, whichever one it will work.
We have a lot of D's.
Okay, great. Next slide, please. Great. So you all got it correct. That D was the correct, go back to that slide, please. D was the correct answer. So I will go through the screening criteria, but 19-year-olds do not need a pap smear yet, but they should get screening for STIs and also make sure get them updated for their HPV vaccination. Next slide. So case two, a 33-year-old female comes in for a routine annual exam. Her last PAP was 3 years ago and was normal. So when should her next PAP be? Again, let's type into the chat. It should be, go ahead and do it today. She's there. Do it in 3 years. Do it in 5 years. I'm really not sure because it really depends on what she had done last time. So I'm seeing some, I'm kind of a little bit all over. Great. Okay, I think the real answer here is D. It really depends on what she had done last time. Next slide. No, yeah. Let's go to a 68-year-old female. She's originally from Somalia. She presents for routine health care. She doesn't have any records and she cannot recall if she ever had screening. She otherwise seems to be healthy. And what is her recommendations for cervical cancer screening? So A, she no longer needs it due to age. She should get a pap test with or without HPV. She should go for colposcopy right away. You should do HIV testing and then decide. So go ahead and type into chat. Okay, great. So I'm seeing most of you actually got it correct that she should definitely get a pap test. Let's go to the next slide. So here's the screening guidelines. Again, this is for average risk individuals. So average risk means if somebody has HIV, they are at higher risk. They are not average risk. Okay, if someone has had a high-grade cervical intraepithelial neoplasm, CIN, they are higher risk. Okay, so average risk individuals. We don't screen, and this is the ACS is American Cancer Society, U.S. Preventive Service Task Force is the other one. USPSTF still states do PAP every 3 years, although that is debatable. The American Cancer Society says don't screen before age 25. And that's because the risk of cervical cancer or an advanced cervical cancer in the very young is really, really small and minimal. Once you reach age 25, then there are a few options for screening. Some of the data says you can just do HPV testing every 5 years if you have that available. The HPV with PAP every 5 years. That's the one I tend to do, mostly because it gives me an opportunity to actually see the cervix and make sure there's nothing else going on. And as long as I'm there, I'm going to do the PAP, and then you can do the HPV with it. PAP every 3 years without HPV is also acceptable. In terms of the over 65, if you have had normal screening up to that point, you do not have high risk, you have not had cervical cancer, you have not had a high-grade CIN, then you can stop screening over age 65. So again, like our last patient, the 68-year-old who we don't know what her screening was, you need to keep screening to make sure that person does not have cervical cancer or high-grade CIN. So this is very common for people coming from other countries where they may not have had screening, or women who may not have had access to care, who have not had screening for several years. Even if they are over 65, you would still want to consider screening them. If someone has had their uterus and cervix removed for non-cancer and non-high-grade CIN, you don't need to screen. They don't have a cervix. So that's important to know that there are times when you can stop screening even earlier than 65 if they meet those criteria. If they have had cervical cancer, you keep screening for up to 25 years after the diagnosis. Okay, assuming that the tests have been normal. Next slide. And I do want to just again point out, I'm trying to have us recognize that there is a lot of inequity and disparity in cancer screening and death by cancer. And you can see that death rates are much higher for non-Hispanic Blacks compared to whites. It's also higher for Native American and Alaskan Natives as well. So again, much of this is due to access to care and following through with appropriate screening. Next slide. So why can we stop cervical cancer screening? Well, there have been several studies that have done that looked at women over 60 or 65. And again, this study showed that less than 0.1% of women who have had normal PAPs are actually going to go on to have any high-grade lesions or cervical cancer. Next slide. Again, 80% of women who have cervical cancer or high-grade lesions have either had no PAPs in the past or have had abnormal PAPs that were not followed up properly to get the appropriate treatment. Next slide. And if we look at vaginal PAPs, again, why we don't need to do it if they've had a hysterectomy, removal of the cervix for benign reasons, again, there were no vaginal cancers that were found in the studies that were done. So again, you don't really need to do a PAP or HPV if they don't have a cervix or uterus for benign reasons. Next slide. So if the HPV or the PAP is abnormal, there are guidelines as to what to do. So I would certainly go to the ASCCP guidelines. And guideline is based on risk rather than strict algorithm. Or you can contact again through MAVEN, one of our gynecology, to say what should you do if you're not really sure what the next step should be. Next slide. So some of the key points for cervical cancer is start screening definitely at age 25. You can screen with either HPV alone, HPV or PAP, which is what I prefer, or PAP every 3 to 5 years. And if there is no cervical cancer, high-risk CIN, or HIV, you can stop screening at age 65 if they still have a cervix. And again, as I've already mentioned, you don't need to screen if patients don't have a cervix that have been removed for non-cancer reasons. Next slide. Okay, so I just want to ask if there are any questions on cervical cancer before I go to the next cancer screening. Okay. And anything in the Q&A? Okay.
No.
Okay. Let's go on to colorectal cancer. As I showed you in the early slides, the epidemiology, this is the third leading cause of cancer-related death in the United States. There's approximately 51,000+ deaths per year, although we do know that screening and better treatment has reduced the death rates by a certain percentage. For most people, there's about a 5% lifetime risk of colorectal cancer, and most of those cancers will occur in people over the age of 50. I did want to say there is a colorectal risk assessment tool. I haven't used it, but you could look at that to see if somebody needs screening at a different time other than the guidelines. And this is at cancer.gov. You can go into it and look and see if that fits for any of your patients to do that. Next slide. Okay, once again, I want to look at new cases of cancer by sex and ethnicity. And as you can see, once again, American, Native American, and Alaska Native and Black tend to have higher rates of cancer, colorectal cancer as well. Next slide. So let's go through a couple cases and then go to the discussion of what the guidelines say. So a 46-year-old male comes in for annual exam. And which of the following is the appropriate for his colorectal cancer screening? You can do the FOBT or FIT annually. You can do the FlexSig now and every 5 years, or you can do colonoscopy now and every 10 years, or all of the above. Okay. Next slide, that's fine. I'll talk about these as a group when I go through the guidelines. Okay, next one, 75-year-old male. He's got history of congestive heart failure, coronary artery disease, comes in for his Medicare wellness visit, and he asks about colon cancer screening. His last one was done at age about 65, and it was normal. So what do you recommend for his? Repeat the colonoscopy now, as it was 10 years ago. He no longer needs it. Discuss risk versus benefit, or it depends on his overall health and prognosis. So again, type into chat what you think. Okay, so I think most of you would say B, C, or D could be appropriate answers, and I would say that's absolutely accurate. Okay, somebody asked me to define the abbreviation. So CHF is congestive heart failure, CAD is coronary artery disease. Next slide. So the colon cancer screening guidelines have changed recently, and the U.S. Preventive Service Task Force has now recommended starting age screening at age 45 for average risk. This is a new guideline, which came out in the past couple of years. You do need to start earlier screening if there is, again, a high-risk person. FOBT is fecal occult blood test. So that's the stool test that you typically will do yourself. And FIT is the fecal immunochemical test. So if you have a first-degree family with colon cancer or other high risk, somebody with Lynch syndrome or family history of that, then screening may need to take place much sooner. Again, also there may be screening that sooner if somebody has a higher risk condition such as ulcerative colitis or Crohn's. But again, you can always discuss that with a gastroenterology specialist to find out what the best timing is for that. So what are the screening tools? So if somebody is high risk, I would say it's a colonoscopy. So if you have a higher risk individual, you want to do a colonoscopy. Otherwise, there is data to suggest that the fecal tests have randomized controlled trials. Those typically have to be done every year, and they are a little bit burdensome, but they can be very helpful. Remember, any positive test needs a colonoscopy. The stool DNA is one of the newer tests, and it's unclear exactly what the screening length is, whether it should be 1 year or 3 years. Those are also a bit more expensive. They're not a bit more, they're a lot more expensive. The fecal tests typically may cost, $10, $20, $30, and the stool DNAs tend to cost over $500. You could do a FlexSig, which usually is done every 5 years. And remember, FlexSigs, though, only can see a certain portion of the colon, whereas colonoscopies try to get the entire colon, including the anterior, the transverse, and the descending. There are also specific timing if somebody does have a colonoscopy and they found polyps, specifically adenomatous polyps. Again, usually your gastroenterologist doing this will give you a time frame for when the next colonoscopy should be done, but it's usually no more than 5 years for most of them. Next slide. So just some of the data around which screening test. So the annual fecal blood test, the randomized controlled trials did show a 33% lower mortality. Again, look at the date on that study. That was a long time ago. Most people have replaced the FOBT with the annual FIT testing, the fecal immunochemical. It has higher sensitivity, and it was a little better at detecting changes that could go along with a neoplasm than the old-fashioned FOPT. But again, as I mentioned, any positive test needs a colonoscopy. It does not need a repeat. It should go to a colonoscopy rather than that. Also, if somebody has had, hemorrhoids and you get a positive FIT test, still needs a colonoscopy because that positive may or may not be from having had hemorrhoids or fissures or something else. For FlexSig, there are prospective trials that have showed a reduction in incidence of colon cancer and mortality. It's, of course, better for the distal colon than the proximal because, again, it doesn't reach the proximal area. And in one of the studies that looked at this, the number needed to screen to prevent one death was 850 people. Next slide. The fecal DNA testing, studies have shown pretty good sensitivity and specificity for adenomas or CRC. The problem with it is it's very expensive. And so many people, some insurance will cover it and some won't. Whether it's absolutely better to do this than the lesser expensive FIT test annually is unclear. So I think if it's resource limited settings, that an annual FIT would be appropriate, except if you think somebody's a higher risk, then you would actually want to get them a colonoscopy. And again, if that's positive, you still need a colonoscopy. Next slide. For colonoscopies, we actually don't have true randomized controlled trials, but there are several case-controlled studies that show a 61 reduction in distal colon and 22% reduction in proximal. So again, that's the advantage of if you're going to do a full scope is to do the full colonoscopy because you get the distal and the proximal. This is usually every 10 years if it's normal. Its other benefit is it can obviously remove polyps and visualize the entire colon if there is a good prep, which is key to having a good colonoscopy or FlexSig. The disadvantage is you do need to take time off work. You get sedated for this. Somebody needs to take you. There is, of course, risk of perforation, which is low in good hands. And it also is operator dependent on how good it is for identifying polyps and removing them safely. Next slide. So what about colon cancer screening in the elderly? And by elderly, we usually mean the over 70, 75 age range. And again, there is higher incidence of cancer as you get older. However, do the benefits of screening actually outweigh the harms of screening? And do we change mortality from the screening? As I mentioned in the beginning, the goal is a 10-year mortality benefit from screening. Next slide. There are case-controlled studies that doing endoscopies could reduce colon cancer mortality by 60%. So that is, when I mentioned what should we do, I think the discussion should come in, how healthy is your older patient? If you have a very robust, healthy 70, 75-year-old, it may be reasonable to continue to do cancer screening for them. If you have, however, a patient who's elderly with a lot of comorbid conditions, where the likelihood of a 10-year survival benefit may not be there, then you may want to advise differently. Again, that is not to say if they have symptoms that you would not evaluate that with diagnostic workup. So if someone comes in with rectal bleeding, you're going to typically work that up unless a patient actually says, I don't want anything. But that's a discussion to have, but symptoms require workup. Next slide. So what do we say about when to stop screening? So next slide. So U.S. Preventive Service Task Force recommends against screening at age 66 or over 75. That's a C recommendation, which means they don't have enough data to really make it either a D or a higher screening recommendation. Over 85, no screening is actually recommended by actually any group. Next slide. ACS and ACG don't really have a stop recommendation, but again, they're not encouraging screening over the 85 age group. Next slide. This is a gastroenterology study, and they say keep screening, and they have a lower life expectancy cutoff than the U.S. Preventive Task Force. And if their life expectancy in this case is less than 3 to 5 years, they don't recommend screening. I do want to say a caveat about life expectancy, and that is that clinicians are actually quite bad at prognostication. And so we actually aren't that great at knowing who does or does not have a high survivability. So I would say it really goes more to frailty of an individual. There are screening guidelines you can look at for frailty tests, a life expectancy. There are several that are online if you want to use those to help inform your discussion. Next slide. American College of Physicians also has an age 75 or less than 10-year. Next slide. And that's American Academy of Family Practice, same as U.S. Preventive Service Task Force. Next slide. So here's the reason about diminishing returns with age. So you can see that there are more cancers as you get older and more advanced cancers, but the year of life gained is significantly reduced the older you get by doing screening and then, of course, the treatment, testing, and then appropriate treatment. Next slide. And there was actually higher incidence of adverse risk, and that's the C-scopes, perforation, sedation, bleeding, and other. Next slide. And again, of course, adverse events are increased by age and comorbidity. Next slide. So some of the key points, I think now the recommendation would be start cancer screening by age 45, possibly earlier, depending if there's higher risk in a family. There are a lot of options, and you can discuss this based on risk factors, a patient preference. It could be access, it could be cost, but make sure, depending on what you are doing, that you have the appropriate follow-up. So again, the least expensive is the fecal immunochemical test, the FIT test, which is a stool test, and that's annually. And again, make sure that you talk to all your patients because we do want to try to reduce bias for screening as well as barriers for screening and appropriate treatment. Start discussing when to stop screening. If somebody is frail, seriously ill, or 70, 75 or older. And again, most people don't really recommend screening at age 85. Next slide. So for the sake of time, you can write your questions in the chat. I will try to get to them. But for the sake of time, I want to try to get to these other screenings. So breast cancer screening. So we know that it is the second leading cause of cancer death in women in the United States. Mammography is still and remains the primary screening tool. There have been studies that show improvement in mortality in the 50 to 74-year-old age range. Incidence and mortality has been reduced by that. And I actually just saw a study in my journals that come across this morning from the Washington Post article that talked about that mortality rates have dropped significantly from 1975 to 2019. And about half of that mortality was due to improved mammogram screening, and half is actually due to better treatment for higher grade cancers. There are a lot of risk factors. And again, this is a risk assessment tool if you want to use it for your patients, because screening may be different if you have a high risk person. So that could be family history, somebody who has the BRCA gene, alcohol, somebody who's been on hormone replacement therapy. Those who have higher breast density, I think, is a question. And anybody who's had prior chest radiation, perhaps from a cancer as a young person for lymphoma or other. Next slide. Again, just looking at some of the disparities in terms of death, that there are higher death rates among Black women compared to other ethnicities. And most of this is usually due to, again, not accessing screening, not following the appropriate guidelines, and then not getting them into appropriate treatment in a timely fashion. Next slide. So couple cases. So 45-year-old comes in for her annual exam. She has no family history of breast cancer, and she wonders if she should get breast cancer screening now, and how often should she do it? So is your recommendation, go ahead and start now and do it annually, do it every 2 years and start now, wait till they're 50, do it every 2 years, but start at age 50, or, oh my God, I'm so confused, I have no idea. So let's see what you would say, just type into the chat. So I'm seeing a lot of A's and B's. Okay, let's go to the next slide. And here we have a 78-year-old female comes in for her annual visit. She has had mammograms annually, and they have all been normal. She's got chronic obstructive pulmonary disease, hypertension, and congestive heart failure. She has difficulty walking 4 blocks, and she asks about mammogram. So do you recommend she no longer needs it? Don't recommend. Continue mammogram, or you're really not sure? Okay. So again, most of you had said she does no longer need it. So let's go to the next slide. So once again, we have a plethora of different guidelines for breast cancer screening. So up here, what I have put on is a table with U.S. Preventive Service Task Force, the Canadian Preventive Service Task Force, American Cancer Society, and American College of Physicians. And so most of these will say from the ages of 40 to 44 that you can discuss it. And that's where I think the risk assessment can be helpful. If somebody may be higher risk, you may want to start screening earlier. The ACS, American Cancer Society, states it's optional to start annual screening. And the American College of Radiology also recommends starting screening at age 40. From 45 to 54, recommending, again, most of the guidelines say to discuss and then do it every 2 years. The American Cancer Society says to do it annually. From 55 to 74, everyone's saying do it every 2 years, but you should screen within that group. And then 75 and above, again, it's that you have to discuss the risk-benefit ratio. If someone has a lot of comorbid conditions, like our patient who could barely walk 4 blocks, that the benefit of screening, the harm is likely going to outweigh any benefit from screening. Okay, next slide. So why is there so much controversy? Well, it's complicated. They have used pooled data for the U.S. Preventive Services Task Force, and there are researchers in different disciplines that argue whether that's the best way. They showed that there is a relative risk reduction of about 15% if you screen in the 40 to 49, which means you have to screen about 2,000 women to prevent 1 death. There also may be a higher rate of false positive because the breasts tend to be a little bit denser than in older women. If you screen the 50 to 59, you still have a relative risk reduction of 15%, and less number needing to screen to prevent 1 death. Going to the 60 to 69, you actually have a better relative risk reduction, and this is for mortality, not morbidity. And again, less than 400 women screened to prevent 1 death. So if you screen with mammograms, it's likely that at least half or more women will have at least 1 false positive, and then possibly needing workup for that. Next slide. So what's the data for every 2 years in age 50? And again, you could argue that this data is variable depending on the studies that were done, the heterogeneity, and how they determined what the studies actually show. Some of the studies, many of the researchers did not feel that there was a huge difference in mortality, whether you do annual or biennial. It doesn't mean that you may not find cancers. But again, remember, screening is for reducing mortality from that cancer. And again, a lot of studies did not show any evidence for screening over age 75, but I think that depends on how healthy your 75-year-old is. Next slide. Again, this was a modeling study. So again, you could argue a lot about whether modeling studies are a good way to go. And they tried to use 6 different models, and they showed that biennial screening, so every 2 years, maintained a benefit of about 81%. There was less false positive results, and the mortality reduction was pretty good for the 50 to 69. There was a slightly higher mortality reduction in the 40 to, if you add the 40 to 49, but there were also more false positives. So again, that's why many of the guidelines have come out with the biennial versus annual, because possibly same benefit with less harm, less false positives. I want to say a caveat, though, for being in primary care, recognizing that sometimes I'm not recommending that you have to do annual, but I am saying sometimes it's easier to remember if you know it's every year. Just because you don't forget, well, was it 1 year ago? Was it 2 years? If they switch clinics, do they remember? Can you get the data to know when they've actually had their mammogram? Next slide. This is for the Canadian guidelines. And again, they did a 25-year-old follow-up for incidence and mortality. They screened over 89,000 women. And again, they found breast cancer in both groups. They had 351 deaths, and their conclusion also was that they had similar mortality between the screened and the control group, actually in both of those ages. Next slide. And then from New England Journal, there were again increased number of cases of early breast cancer when you do screening. And you decrease late stage presentation. And I would say that is one of the benefits of screening and screening early is we don't want to find people in a stage 4 diagnosis where the mortality and morbidity is much higher. And then we have an incurable condition rather than a potentially curable one if we find cancer early in a stage 1 or stage 2. There is, again, a lot of overdiagnosis in their study, but they did have 28% reduction in death. Next slide. So again, I'd say the risk of mammogram for any of those who have ever had one, no, it's not comfortable to do a mammogram. There can be, of course, overdiagnosis of both breast cancer and breast lumps, some of which may become clinically apparent and others will not, and some may cause death and others may not. And again, there is risk of radiation over time. Next slide. And then people ask a lot about, well, what about dense breasts? And again, it's unclear whether dense breasts actually increase risk of breast cancer or makes it harder to find because of the density of the breast. And this really is more about which study should you get, the regular digital mammogram or a digital mammogram with what's called TOMO or the 3D mammograms. And there actually were less false positives with the 3D mammograms. I have asked my radiology colleagues about the difference in cost between a standard mammogram or the digital TOMO, and there does not seem to be much difference in cost. So my institution actually just shifted over. Everybody gets TOMO mammogram. They don't do the regular anymore. So if that's available, that may be more beneficial to reduce risk of false positives and having to recall. Next slide. So what should we do? Definitely by statistics, the highest value for screening is in the 50 to 69-year-old, but it should be a shared decision-making between 40 to 49. And again, please remember that with equity and disparity, we do want to be sure that all women get their mammogram screening. You can use the risk calculation to see if somebody is higher risk. Certainly someone who has family history in their family, first-degree relative, you may want to consider genetic testing, but you actually would probably want to start them at the younger age. Definitely, if they come in and they have not had screening, certainly you should start screening by age 50, and then you can discuss whether to do it annually or every 2 years. And again, the newer mammograms, the digital with TOMO are better. There does not appear to be any benefit of screening after the age of 80, but you could consider continuing screening if they are healthy and they're in their 70s. And then remember, if they have symptoms of any kind, you move to a diagnostic workup that is no longer screening, that is diagnosis. So if they come in with breast pain, lumps, rashes, discharge, or anything else, you need to do a diagnostic workup and try to get an answer for that. Next slide. Okay, so before moving to lung cancer, I see there's somebody asked, what is the false negative rate for the FOBT? I don't know the answer to that. I don't know what a false negative rate is. They tend to do it more as false positive. So it's a good question, but I have not seen any statistics for that. Are there any other questions on colon or breast? I'm going to talk about PSA in a little bit, Susan, so I'll come back to that question if I haven't answered it. Are there any other questions for breast or colon or cervical? Okay, we're now going to move to lung cancer screening. So remember, this is the leading cause of death for both men and women in the United States. I do want to emphasize that the most important risk reduction strategy is to get people to never smoke or clearly to stop smoking, because most cancers are related, most lung cancer cases are related to smoking. That does not mean that people who have never smoked cannot get lung cancer. But again, the higher risk individuals are those who have smoked. So again, typically almost close to 200,000 cases, and you can see a significant portion of those cases lead to death in the United States. That's usually because by the time lung cancer is diagnosed, it's usually later stage, it has metastasized, and it becomes an incurable condition treatable but incurable. We do know that there has been some reduction of incidence with better screening and treatment, actually, and that those seem to be stable, thankfully, across different ethnicities. Next slide. So just a couple cases that we want to think about. 65-year-old male, he's a former smoker. He had 23 pack years. He quit 10 years ago. He has family history for coronary artery disease, but not for cancer. So what is the appropriate screening for him? Should he get a PSA? Should he do a colon cancer screening, get a chest CT, abdominal aortic aneurysm, or all of the above? Great. So most of you recognize that all of the above is the correct answer for this patient. Next slide. How about a 50-year-old? He's a current smoker with 35 pack years. He doesn't want to quit, but he heard about this lung cancer screening stuff and he wants your opinions. So what do you think the guidelines say? He should not have screening because he's still smoking. He should have screening because it could be beneficial. He should have a chest X-ray, and that screening reduced lung cancer mortality by 50%. So okay, great. Most of you have it right. Yes, he absolutely is eligible to get lung cancer screening. Sorry, I'm just going to go back. Somebody asked a question. What's the false positive rate for FIT versus Cologuard? Excellent question. I wish I had that answer. They have not done a head-to-head study for that. I can go back to those slides to see if I wrote down what their false positive rates are for those. I wrote the sensitivity specificity. Unfortunately, I did not write down the false positive, so I can try to look that up for you and get that back to you. Okay, let's go to next slide, please. So the lung cancer screening guideline recommendations are to screen annually in those who are eligible with what is considered a low-dose chest CT scan. The criteria are they have to have minimum of 20 pack year smoking history. So you have to identify, and this was actually lowered recently in 2021. It used to be a higher pack year. So 20 pack years. So if I was a smoker and I smoked 1 pack per day for 20 years, I have a 20 pack year. So you may need to do some calculation. If they are a current smoker or have quit within the past 15 years. So both of our patients would qualify. One quit 10 years ago. The other one is still smoking, and they both have over 20 plus pack years. They have to be between the age of 50 and 80. And again, that's also a new criteria that they dropped the age down to 50. It was starting at age 55. And again, we are trying to find early lung cancer where treatment would clearly outweigh, would have more benefit than waiting until somebody got more clinically apparent cancer. They should have, again, a life expectancy of greater than 10 years. Again, take that with a grain of salt, depending on our ability to identify true life expectancy. And they should be willing to undergo whatever treatment may be necessary if a cancer is found. Next slide. So what's some of the data for these criteria? So there was the Dante study, and this looked at men in particular. So notice most of these studies were predominantly men versus women, had a 20 pack year, and they compared the annual low-dose CT scan versus a control, which was a chest X-ray. And they found that there were 60 lung cancers in the low-dose CT versus only 34 in the control. They did find lower stage cancer by doing the CT. So this is why chest X-ray is not a screening test for lung cancer. Okay, chest X-ray is not a screening test. It has to be a low-dose CT scan. That does not need contrast. There was, of course, more invasive procedures for benign disease if you did identify a mass or a lesion on the low-dose CT. Next slide. The NLST, again, was a randomized annual CT versus chest X-ray. Again, they used people with higher smoking history and the older age starting at 55. They found lung cancer, obviously, in both groups. Death was fairly similar, slightly lower in the CT screening. They did find a 20%, however, relative reduction of mortality, and that was the key to getting approved for the CT screening, that 20% relative reduction of mortality. There was, of course, pretty high incidence of overdiagnosis. And the number needed to screen to prevent one lung cancer death was 320. So that is actually fairly reasonable for screening to prevent one death. There may be higher complications. It is radiation. And there may lead to more false positives with overdiagnosis and unnecessary biopsies. But again, lung cancer is the leading cause of death from cancer in our country. So again, it does require some discussion of the risk and benefit. Next slide. And here is just some of the charts that I think is a little better to see, that you can see that 20% reduction with the low-dose CT versus just a plain chest X-ray. And again, you don't tend to see the benefit until you get out 2 to 3 years from the screening. Next slide. And one more study to just talk about this was, again, low-dose CT without versus no screening. And these people were followed for longer than some of the other studies. In the non-screen group, there was a much higher incidence of advanced cancer. And again, if we can identify lung cancer early, we do have a much higher chance of reduced morbidity and mortality from this condition. Fairly good sensitivity and specificity. A positive predictive value is about 40%, but a negative predictive value, so that means if you have a negative test that has a very high negative predictive value, that they don't have lung cancer. So that's where that test is helpful. Next slide. So what do we do? So first and foremost, get people to stop smoking. And preferably, we don't know vaping or cannabis or other things that also could injure the lung. We don't have data on those substances yet. We might. Personally, I would not have people smoke anything, put that into their lungs. You need to determine how many pack years of smoking, and then those who are eligible, I would certainly recommend doing the low dose CT annually. And again, please remember they should be willing to undergo treatment, including surgery. So sometimes people may not know, or they may say they think they're not going to do it, but if they find something, many times people do change their mind. So I would use that caveat with a bit of a grain of salt as well. Next slide. So now I want to get into the one that I think has probably the most controversy of all the cancer screening, and that's prostate cancer. So it is the most common cancer incidence in men and the second most common death from cancer in men. The PSA was introduced back in the 80s. It was initially utilized for monitoring treatment, but then because it had a fairly good sensitivity, not necessarily specificity, that they actually started using it for screening. So PSA is, and that's prostate-specific antigen, is the first test of choice for screening. A free PSA, which includes a percentage, so you would get free total, may be helpful not as an initial screening, but as a follow-up test if you have an abnormal routine PSA screening. And depending on the age, greater than 1.5 or higher may be indicated. I will give you a link for a risk calculator that could be helpful for patients who may need referral or additional testing based on those results. Next slide. So let's just talk about a case. A 44-year-old male comes to clinic to establish care. He asks about prostate cancer screening as he's been reading about that in the news and wants to know what he should do. He has no idea about his family history. And so what do you tell him? Don't screen because the U.S. Preventive Task Service says no. Discuss the benefits and harms and do shared decision making. Do a direct or digital rectal exam. That's what a DRE is, because it's better. Or, gosh, I have no idea. That's why I signed up for this lecture. So which do you think? Okay. I appreciate those that are honest who said D. I don't know, because honestly, I think that's where I always sit, but B is certainly reasonable, that we're talking about some shared decision making. A DRE is not more beneficial than a PSA for screening, but a digital rectal exam can be very important and should be part of your physical exam, examining a male, because you might feel an abnormal prostate. Next slide. And again, I want to thank Dr. Stephen Lieberman, who is one of our MAVEN volunteer urologists, for some of this discussion. And I'll give you a link later in this talk where you can listen to him talk a lot more about prostate cancer screening and treatment. So early detection of prostate cancer, I don't believe is controversial. What is controversial is what is the best way to screen and who to screen. So early detection of any cancer is not controversial. If we can find a cancer early, a patient has a much higher likelihood of survival. There is no such thing, quote unquote, as a real normal or quote unquote an abnormal. So it actually is risk-based and it actually is person-based. So we have norms, and some of us may feel comfortable saying, oh, well, it's in the normal range, but a 40-year-old who has a PSA of 2, that actually might be a high PSA and may require repeating the test. And before you actually talk about the shared decision making, you should have some idea of whether knowing the risk of a high-grade cancer, and that's where these risk stratification tools can be helpful. Not everybody who has a high PSA actually has prostate cancer. There are a lot of things, again, that can give you a high PSA. There are prostate cancers that will not cause death. Or morbidity. And so again, there's a lot of information that will need to be discussed should you get an abnormal and do a risk stratification and see should this person go on for more testing. And again, remember, anyone with symptoms, urinary symptoms, frequent urination, dribbling, pain, rectal pain, back pain, you know, it's pressure sensation. Those are symptomatic findings and they need a workup. So they should have a digital rectal exam. They should have a PSA. You may need a urinalysis. You may need an ultrasound. There may be other studies that are needed to try to figure out why are they having those symptoms. Prostate cancer may only be one of those in the differential. Next slide. So here again, controversy with the screening. So the most recent guidelines have come out from the American Urologic Association. And a new recommendation really just this past year is to actually offer baseline PSA screening starting at age 45. You may consider screening earlier, especially if there's positive family history, if you know that they have mutations, if maybe they had a PSA done for some other reason and it was more elevated. The screening in men, assuming you had a normal or low PSA in that earlier age group, then you get screening every 2 to 4 years in the age group 50 to 70. Again, a lot of controversy about older age men 70 plus, again, going to the survival. Many of the organizations say don't screen after that. Again, I think it would depend on whether you have a healthy 70-year-old. Because again, if we can catch somebody who might have an early cancer that might be a higher risk, then we are actually saving them from a lot of morbidity and mortality down the road. The U.S. Preventive Service Task Force recommends starting screening aging 55 to 69. Again, they changed their criteria. It was don't screen. Now it's talk about screening because, again, it's the shared decision making. They also don't recommend screening older age groups. I would say that one of the criteria for USPSTF was the overdiagnosis rate. So people going for pretty aggressive workups, biopsies, and things like that. But I think there are some newer studies and newer workup that can be done that are less invasive that can markedly reduce the risk of unnecessary biopsies or complications from that. American College of Physicians says start screening at age 50. And they say screen at least once, but then after do informed shared decision making. Again, that doesn't really help a lot as the older age group. How do you know someone's changing? Most people have gotten away from the rise of velocity, which is a PSA that goes from, say, 0.5, and then the next time it's 1, that how quickly that happens may be less useful than, again, doing the risk stratification and the actual PSA. For American Cancer Society, they recommend that any man who has greater than 10-year survival to discuss it. If they're African American or family history, the ACS recommends starting age screening at 45, which is very similar to the AUA guidelines. Next slide. So again, this is taken from Dr. Lieberman's talk. So if the prostate, again, for many cancers, if we find them early, where they are very localized and defined, your survival is significantly better. Once somebody has advanced or metastatic disease, their survival goes way down. You can see that at 30%. And most men who have localized disease usually do not have any symptoms. If you get to a stage 3 or stage 4 cancer, in most cancers, those are treatable, but they're usually not curable. And there is a lot of, we don't always talk about the morbidity, and screening studies really didn't look a lot at morbidity. They were really looking at mortality, but there is a lot of morbidity and expense associated with treatment for those stage 3 and stage 4. And then also a lot of morbidity with metastatic. They can get, bone lesions, a lot of bone pain, increased risk of breakage and fractures. Next slide. This is the Cleveland Clinic risk calculator. So it is designed for men 50 years or higher. So that's why this calculator can be used to try to get at how old a person is and what their risk might be. It needs specific criteria. So the ones that you have to have is how old are you in years? Is there a family history, ethnicity, and the PSA level. So in order to use this calculator, you actually need a PSA level. Whether somebody might have high risk, go to the next slide, please. That's where you might consider getting then a repeat PSA, total PSA with the free PSA, which is a %. And actually, this is interesting. It's a little counterintuitive. The higher the free PSA, the lower the risk of a high-grade cancer. Okay, so I know I had to go over this a few times, but if you have a lower free PSA, then you actually have a higher risk of a high-grade prostate cancer. So if you were to find a higher risk of prostate cancer, and that could be anything over 5 or 6%, you may want to go either talk to urology. Should this person get a prostate MRI? Should they get some other test? Should they see a urologist? So that may be a discussion that happens if you find that their risk calculation is significantly higher. Next slide. So what should we do? Dr. Lieberman, who's a urologist and does a lot on prostate cancer, recommends actually starting screening at age 40, so even going lower than any of the guidelines say. And that is regardless of race and family history. He then says if you have a PSA that is over 1.5, that somebody who is that young that has a high PSA, and remember, don't do a PSA if they have a prostatitis, a urinary tract infection, if you've just done an aggressive digital rectal exam, if they just got off of, 2 hours of biking on a sitting on a bike, because any irritation of the prostate can cause an abnormal PSA. So it's always good if you have a higher PSA, repeat it, making sure there isn't anything else that could contribute to a high PSA. But those patients he feels might have a higher risk of the high-grade prostate cancer, and they should be screened and even consider referring to MAVEN Consult for urology. And he puts the link in there to the article that talks about that. If you have a lower PSA, then repeat the PSA at age 45, which are the new AUA guidelines. And then if it's still lower, below the 1.5, then again, repeat at age 50, and then consider doing it every 2 to 4 years according to the guidelines. If the PSA is greater than 1.5, again, in that 40-year-old, repeat it with the free PSA, and then determine if it's still high. And if they do have higher, again, I would probably talk to the urology or get the e-consult before going on to some more expensive studies to know if this is somebody who should have that, who should see urology or whatever. But there is now an MRI that can be done of the prostate, which is almost always done before any biopsies are done. Next slide. And here's the podcast with Dr. Lieberman, who talks a lot more about this and is a lot more knowledgeable in terms of PSA screening. So I'd recommend that you consider listening to this to get more data and information. Next slide. No, we're not going to run it. Next, there you go. What about other cancers? So I get a lot of questions in my practice about screening for uterine or ovarian, pancreatic, thyroid, and there right now are no screening guidelines for any of these cancers. So that's where I really think that in primary care, taking a very good history and doing a good physical exam is really important to help. If a woman comes in with vaginal bleeding and she still has a uterus, then you need to consider a workup for that, because we do not want to miss uterine cancer. Ovarian cancer, again, unfortunately tends not to have a lot of symptoms until it is later stage. But those early symptoms could be, again, abdominal pressure. It could be nausea. It could be, a sense of just abdominal, reflux or pressure sensation. So really go back to those symptoms and physical. For skin cancer, again, skin cancer can be very common, and I think the skin deserves a good look, at least annually. So when I have my patients in for their annual exam, I actually have them undress so I can look at their skin. I know we are at the top of the hour, but there was a question about, are there any screening tests for bladder cancer? I'm not aware of any screening tests, but clearly if you get a urinalysis and there is blood, even microscopic, you need to consider working that up for that, but that's not screening, that's diagnostic. So I'm sorry I went a few minutes over. I know it was a lot to cover, and could somebody put the link for the chat? You will get these slides, so you will have the link to that webcast once you get the slides. And thank you so much for having me do this discussion. I will stay on a little bit if anybody wants to stay on and ask any questions.
We'll stay on and we'll keep recording. So if you do have to hop off, you can get the answers to those questions when the recording's available in about 2 weeks.
Yeah. So, somebody asked, are there any resources that say what PSA level is normal for what age? So this was something, again, that I learned a little bit more of with Dr. Lieberman, is there really isn't a quote unquote normal. I know our lab has normal ranges, And I think the point he was trying to make in urology is you need to individualize that based on their age, not on what a lab says is normal. So again, as I mentioned, if somebody who is 40 and has a higher PSA of 1.5, then you want to repeat the PSA with a free PSA, which will give you a free and a total and then a percentage. And then that should help you determine, you can use that for that risk calculator and determine if somebody should have further workup or see urology. So I hope I answered that. Somebody had screening for prostate as a diagnosis. I don't know why insurance would refuse to pay for that. I can ask again, Dr. Lieberman, what diagnosis code he may put down, because I think screening for cancer should be covered. I'm not sure why it isn't.
I'm going to put Dr. Lieberman's PSA talk, the link to it, which you also have access to on your MAVEN project portal on the on-demand library under educational sessions. But I'm going to put that session, the link in. It's also a session that you can request. And if
Yeah.
you have like specific questions about PSA or the insurance with that, you can always send Dr. Lieberman a e-consult.
Yeah, I would do that. And I think that may also be very dependent on which insurance, because I know if I put in screening for prostate cancer, for many of my patients, it does get covered. So I think that may be very dependent on what insurance, perhaps even what area. And I think part of that problem and perhaps part of that discussion, advocacy, we should do is, screening tests for cancer, especially ones that are so controversial, should maybe be covered. Um,
Looking at the Q&A. Ooh.
yeah, looking at that. So the question about dense breasts. So that's always a question. A lot of times a lot of the radiology are reporting that. What I would say is if they didn't find anything abnormal and they're not having symptoms, I would simply say that, many women have dense breasts. I would try to find out if their mammogram was the regular older mammogram or whether it is the newer 3D tomo mammogram. Uh, and what I would tell that woman is, assuming they have no symptoms, no, they're not high risk, uh, I would repeat their mammogram next year, as per some of the guidelines, and make sure that they do the 3D tomo. So the one that has better pickup and less false positives and false negatives than the regular mammogram.
Great. Well,
Any other questions? Okay, I'm not seeing any others come in. So thank you so much, and thank you for staying later.
thank you.
Okay,
We appreciate it. Have a great day, everyone.
okay, thank you so much.